5, 4, 3, 2.
Good afternoon, my friends. Welcome back. The doctor's in the house. Welcome back to another episode of To Your Health with Dr. G. My name is Dr. Mark Gomez. I'm a board-certified internal medicine physician practicing out here in the Chicagoland area in the western suburbs. So welcome back, everybody. And I'm excited to introduce the new series for this month. And really, this is kind of a culmination of a lot of thinking, but also thinking about what's important out there to us as people as we take care of our families and our loved ones. So this month is my kicking off to the Cancer Sucks series. That's right, hashtag Cancer Sucks. And really what this month is going to be about, it's going to be about me and my group of experts breaking down cancer. So each week I'm going to be joined by a group of experts, and we're going to talk about a specific cancer. Today's show is actually about colorectal cancer, but again, we want the show to be about awareness. We want it to be about screening. We want it to be about treatment. But more importantly, we want it to be about survivorship, continue to do things in this life on this planet with our families and our loved ones. And lastly, not to take your health for granted. So I'm excited to welcome you guys to the Cancer Sucks series. This will be the first annual one. And I'm excited to just bring some great content to you guys. So I want to certainly thank our platinum level sponsor, Phillips Eye Center, for the show. And again, we're going to talk about some really important topics with cancer, and today particularly colorectal cancer. Before I introduce my guests and everything, I do want to hit you guys with a quick disclaimer. So here we go. The content of To Your Health with Dr. G is for informational and entertainment purposes only, and that the content is not intended to be a substitute for professional medical advice, diagnosis, and or treatment. Further details can be found at www.toyourhealthwithdrg.com/disclaimer. So again, welcome back everybody to the show. Certainly we've been thankful to the fans out there who tune in each and every week to listen to us and to listen to our mission about engaging people in healthy behaviors and really giving people that chance to take advantage of their health and their well-being. For those that are new to the show, what I do is each week I break down a topic with my group of guests, or guests in today's particular. Got one guest today. I'm so excited to introduce him to you guys. But each week we break down a topic. We want to make sure that people are armed with information so they can make proper health decisions for their family members and their loved ones. Again, my name is Dr. Mark Gomez. You can check me out on my website, www.drmarkgomez.com. You can check me out on Twitter, Instagram, and Facebook. My handle is @toyourhealthdrg. So again, we're talking about cancer sucks, and that's going to be the theme for next month. And cancer really does suck because it impacts everyone that we know. Cancer is the #2 cause of death in this country. It falls behind cardiovascular disorders. But we're going to break it down, and particularly we're going to break down colorectal cancer. And what I want to do before we kind of get into some more statistics of colorectal cancer, I do want to welcome my guests to the show. So I certainly want to welcome my good friend, Dr. Darren Kastin. And Dr. Kastin and I, we've known each other for a long time. Many years working together at Edward Hospital. I know him professionally and personally as well. He's been on the show before. If you guys remember from our 6th episode, we had Dr. Kastin on our obesity show, part 2 back then. So check that out if you missed that episode. But Dr. Kastin, I wanted him to come back onto the show and talk about colorectal cancer. Dr. Kastin is a board-certified gastroenterologist. He's also board-certified in obesity medicine. He's with the group Suburban Gastroenterology Ltd. Check them out at www.sgihealth.com. Dr. Kastin, welcome to the show.
Oh, thank you for having me back again.
Hey, I'm so excited to have you here. Again, this is an issue that certainly you see on a daily basis as your role as a gastroenterologist, and so I know you can speak volumes and speak from the heart on the impact of colorectal cancer on our communities. So what I want to kind of do, just kind of tell me just a day, what's like a typical day for you when you're dealing with colorectal cancer? I mean, what do you know, I'm sure you're doing your scopes, you're doing things like that, but what's kind of a typical day in relation to the scene? And maybe I should back that question up a little bit. How important is colorectal cancer? You know, we got to create that urgency, but how common is it?
Well, colorectal cancer is the second cause of death due to cancer in America, so it's very common. I think the problem is that a lot of patients think that they're supposed to have symptoms or going to have symptoms, and that if they don't have symptoms, that they don't really need to be screened because they're fine. And that's really not true, because colorectal cancer can be silent and can present as a coincidental finding when they're having just a screening colonoscopy. And that's why we do screening exams.
Yes.
And that's what's so important. I think that the hardest part of my job is diagnosing colon cancer in someone and having to sit down with them and present that diagnosis to them. But I always try to make sure to follow that up. When we walk into a patient's room, we've got a plan. And when we tell them that we found that, we're grateful. We're grateful that we found it usually in an early enough state where we can intervene so that their quality of life and their longevity is preserved. And I think that's probably the absolutely critical thing. So there's some reward in that, in them knowing that we can help them.
I know my job as a primary care physician, being on the front lines as an internist, certainly from my end, the goal is to make sure that our patients have those age-appropriate cancer screening protocols done. And you mentioned colonoscopy. When we think about cancer prevention, screening is one of the most important things ever. And so we're talking about colonoscopy, and the goal of screening is to find any kind of precancerous lesion, any abnormality before it can become cancerous. And certainly when it comes to colonoscopies, why don't you tell me this? Well, how common, or I should ask you this question: how common is it, or what's the best age when somebody should start out with a colonoscopy? And can you explain a little bit to our audience what is a colonoscopy? We'll start there first. What is a colonoscopy?
Sure. Well, a colonoscopy it's an examination of the colon, which is also referred to as the large intestine or the lower intestine. Patients typically go through a mild change in their diet the day before a procedure, and then generally the night before they have to drink a type of fluid which tends to wash out and clean out the colon. And that tends to be the most challenging part of colonoscopy for a patient. They generally will come in to an endoscopy unit, which is an outpatient type of procedure. They don't get hospitalized, even if the procedure is done at the hospital. They are usually there for maybe an hour or two, and the procedure itself takes about 15 to 30 minutes. And they're sedated, they're asleep, so they don't generally remember anything. They don't generally feel anything. And the procedure involves placing a camera with a light into the behind and then gradually guiding it around the colon. And I think that's, the screening times typically are the age of 50 for men, white men and women. The African American population actually sees a higher rate of colon cancer, and as a result of that, we recommend that they're starting at 45. And in fact, just recently, the American Cancer Society actually just suggested that patients all begin screening at 45. The Gastroenterology societies haven't quite changed that yet, but they're evaluating that, and they'll make some changes, I imagine, in time.
Yeah, I remember that came out just a few weeks ago, as a matter of fact, with that new recommendation to start at 45. I want to actually take this down. I'm going to take a couple steps back, and I want to break this down to more of a granular level, because I don't want to assume that everybody knows what cancer is. We all hear about cancer. We hear the word and the associations of it, and a lot of times you hear you associate devastation in terminal type words with cancer. But let me break down cancer before we get back into some deeper stuff on colorectal cancer. So for those out there, cancer is a term used for diseases in which abnormal cells divide without control, and those abnormal cells, as they divide without control, bypassing your normal checks and balances in your body, those cells can invade other tissues. And we know that cancer cells spread throughout the body through the blood and the lymph systems. And cancer is just not one disease. It's not just like cancer. There's so many different kinds. It's in many diseases. And as a matter of fact, there's over 100 different kinds of cancer. And so when we talk about prevention, yes, out there as a primary care doctor, I say, yes, we got to make sure you're a certain age, we got to get certain things done, because we don't want people to succumb from the second most common killer in this country. I don't want them to succumb from heart disease either, too, so we're still working on that. And so when I think about prevention, we think about, yes, screening, and I'm going to ask Dr. Kastin a little bit more about some of the techniques that are out there for colorectal. Vaccines. Vaccines are out there when we think about cancer to help lower risk, and this is not anything to do with colorectal, but you think about HPV vaccine or human papillomavirus vaccine to help prevent most cases of cervical cancer and several other kinds of cancer. Or like the hepatitis B vaccine, and being a gastroenterologist, helping to lower liver cancer risk. But also, and Dr. Kastin and I, I'm sure we'll talk a little bit about this too, on some of the myths that are out there, but your lifestyle has a role to play. And so I know as a gastroenterologist, you talked to me, and recently board certified in obesity medicine, so I know you're talking about lifestyle a lot when we look at a certain percentages of cancers being associated with overweight and obesity status. So I want to hit everybody with a couple quick stats because I want to talk about the impact of colorectal cancer. Dr. Kastin just kind of alluded to it. Certain populations have very much higher risk of succumbing to it. So I pulled this off of the American College of Colorectal Surgeons website. So this year, 67,000 new cases of colorectal cancer will be diagnosed in women. Colorectal cancer is the third leading cause of cancer death in women. 62,000 new cases of colorectal cancer will be diagnosed in men. And then 56,000 people in this country will die from this disease this year. Slightly more than 50% of them will be women. And as Dr. Kastin alluded to, African Americans certainly at a higher risk, and we're seeing a little bit of the more risk in the Latino population, correct?
Yes.
Okay, so
Exactly.
you're seeing that one. So let me ask you this. As a primary care doctor, one of the most common things I'm faced with is I say, hey, you're due for a colonoscopy, and then people never get it done, or you see them again a year. What's the problem in delaying that? And what kind of barriers are you seeing from your end on why people don't want to go through colonoscopy? Is it the prep? What kind of barriers are out there?
Well, I can tell you that patients definitely don't want to do the prep, and when they've done it, they never forget it. I did the prep, and I added some Crystal Light to it, and it ruined Crystal Light forever for me. So
it's like never again on Crystal Light.
I'll tell you, it's a challenge. I think that primary care doctors play an absolutely critical role in getting patients to come for the colonoscopy, because when they come to see me, they're seeing me for the first time, but they're seeing their primary care doctors repeatedly, and those doctors, the good doctors, and the doctors who are really advocates for colon cancer screening, like you are, for example, really make an effort to take that relationship that they have with their patients and help their patients understand the importance of it. The reality is that patients are scared. Sometimes they just don't want to know. Sometimes they convince themselves that because they're not having any problems and because they're healthy, that they don't need a colonoscopy. And I think that and there are other patients who have difficulties with access, barriers with access, and there are other factors too, that there may be some cultural factors, because we see patients who have different ethnic backgrounds. But I think that in those patients, what we try to do is make them understand that any form of screening is better than no form of screening. And there are other screening modalities out there, not just colonoscopy.
I like how you say it. Any form of screening is better than no screening at all. And that gets back to the kind of the quintessential issue of prevention. We go into this profession as physicians. We're here to help people. We're here to hopefully make a difference and help people live productive, healthy, and happy lives with their families. And this is where certainly for me, as a primary care doctor, I say, listen, I want you to be seen by me once a year at the minimum for your physical, and at that time we can go through all this kind of stuff. And it's almost like a checklist, but in all honesty, you have to kind of have that checklist. We want to make sure that your body's not breaking out. I don't want my patients to have any surprises. That's just kind of maybe my thing. And so when it comes to colorectal cancer screening, I push it like crazy, and it does get a little bit frustrating at times when I might see somebody back in my office a year later or 6 months later for another issue, and then I kind of say, hey, Mrs. So-and-so or Mr. So-and-so, hey, did you ever go get that colonoscopy? And then they say, oh, well, I didn't have time, or I don't want to do that prep, or I hear stories that colonoscopies are bad for you. And I go, how is that bad for you? So I'm sure you hear all sorts of stories from people coming in, but how do we kind of just break down that barrier even more? I just feel like I want to have people to get these kind of things done. I can't force anybody, but we want to get that done. How do you have that conversation?
Well, the first thing I do is I reassure them that that colonoscopy isn't bad for them, for sure. And patients, you're right. Patients bring stories. They bring all kinds of stories. They tell us stories. Well, I heard, my friend had something happen, and they didn't feel well after the procedure, and we now, every periodically, every year, every so often, we reevaluate how we do colonoscopy. And we improve our techniques, and we improve our ability to detect polyps, which are the abnormal growths that we want to remove before they ever become cancer. And I think that it's about education. And we're not going to capture everybody, but I think that the more we educate patients on the importance of colon cancer screening, and I got to tell you, I mean, colon cancer is one of the most preventable cancers.
There you go.
I mean, look at the huge drive that there's been over the years for breast cancer screening, and how breast cancer detection and death from breast cancer have been reduced over the years because of aggressive efforts at screening. Well, we can do the same thing with colon cancer. There just needs to be better awareness and more information to the patients.
I like how you say, and going back to education, as you mentioned a few moments ago, like trying to get this message out, and I think like a medium like this show is a way to get things out there. You know, if somebody can hear just that one message and that can make that next difference, I think that's important. If I can tell all my patients to get those colonoscopies, if I can do something to get them there, I would love to. And it's interesting from a primary care perspective, I have a roster of all my patients that actually are not up to date on screening, at least from what we can gather in the electronic medical record. So that gives me a little more of a catalyst to kind of get people in. So I have my step. I say, all right, call Mrs. So-and-so, call Mr. So-and-so, find out if they had their colonoscopy, find out if they were seen, and they found through on that recommendation to see you, as a matter of fact. And then they'll call in and they'll say, no, sorry, Dr. G, the patient wasn't seen, and but they're going to make that appointment soon. And I kind of say, hey, that was a year ago when we saw your physical. Now time happens. So let me ask you this question. What about like, say somebody's got some symptoms, and maybe we can talk about this because sometimes people want to know, hey, if I think I might have some concern for colon cancer, what kind of symptoms are you seeing? I know everybody may present a little bit differently, but is there any like a classic constellation of symptoms that might suggest an underlying colorectal cancer?
Well, I can tell you there's probably no classic constellation of symptoms, because colorectal cancer, depending on where it develops, whether it's in the rectum or in different parts of the colon, are going to grow differently and present differently. But what I can say is that what brings a lot of patients in on their own is when they see some blood. When they see some blood, either after a bowel movement or on the toilet paper and they're wiping, it usually turns out to be hemorrhoids. Something simple, but that's what brings patients in, and that allows us to have the conversation, to break down that barrier, as you say, to have that conversation about the importance of colonoscopy. And obviously, our primary care physicians make a great effort to do some of the other screening tests, looking for things like hidden blood in the stool, which will often, if it turns positive, will lead to a referral. And that gives some punctuation. The patient feels now that it's become more important. Other symptoms can be very nonspecific, maybe mild abdominal pain, or maybe just a change in their bowel pattern. Maybe they're a little constipated, or they've noticed a little bit of change in the way that their bowel movement looks compared to what it used to look like. I will say that weight loss is always something concerning, but it's not generally typical for colon cancer.
Okay. No, that's great for clarifying that. Usually when I'll see cases of cancer or concerned about, one of the things that people commonly read about is like, I've got unexplained weight loss, I've got lack of appetite, and so things like that. So it's not necessarily the case.
And that's a less common symptom with colon cancer.
Yeah. So thanks for giving us a little more information on that. Now, I want to go back to the colonoscopy. And again, one of the barriers out there, one of the myths, people say, oh my gosh, it's going to be painful. And certainly, again, the barriers, I got to drink that prep. And yes, you need to be cleaned out, because the last thing you want is have an inadequate prep and potentially miss something important. Could you expand more on that? If you have like if people may not finish their prep, or if there's a poor quality of the prep, or maybe they don't drink it at all. Some people just say, well, why do I have to have a prep? I mean, well, you got to be seen, right? You want to be able to see things. What would happen if they didn't do a prep and you were trying to stick a scope up there?
Well, it would be a mess. And that may be maybe I should just leave it at that. Over the years, the way that we prepare patients for colonoscopy has changed. We used to give them a large amount of fluid that they would have to drink all at one time, and patients had a real difficult time doing that because it was so much volume, and it would make them feel full and nauseated. Now we break that up. They don't drink it all at the same time. They split it up, and when they do that, they tolerate it better, and it clears their colon better. I will say that colonoscopy isn't painful. that really is a misperception. The patients are sedated for colonoscopy. They're given a mild sedative. They're not under general anesthesia. They're breathing on their own. And from our perspective, they're sleeping. And from their perspective, they're sleeping. They're breathing on their own, and they're comfortable. Sometimes when they wake up after the procedure, they feel a little bit of some gas discomfort. And literally just passing that gas alleviates the discomfort. They can eat and drink normally after their procedure. And generally, it's only that one day of the procedure that we ask them not to drive and to take off of work. The next day, they're back to work and feeling normal.
Excellent. Out of curiosity, how long, for people out there that don't know, that may have never had a colonoscopy, how long, in kind of a typical case that's unremarkable, of course, how long does a colonoscopy take from the time they get that mild sedative until you're basically done?
15 to 25 minutes.
Okay, so that's actually not that bad when we're talking about,
Very short.
some people may have that misperception that, oh my gosh, I'm going to be there all day long and the procedure's going to take an hour. So that's very nice to know that people can get this done in a relatively short amount of time.
Yeah, the bulk of the time when they come into an endoscopy unit is the time it takes to register them, to start the IV, to get them changed into a proper gown for the procedure, and then some recovery time afterwards. The procedure itself is generally very short for most patients.
Excellent. I want to take a moment right now to acknowledge our platinum level sponsor today, Philips Eye Center. The physicians at Philips Eye Center are committed to providing the highest quality of comprehensive eye care to our patients. They offer a wide range of ophthalmic services, including laser and surgical treatments for many diseases of the eye. Just a few of their services include surgical and medical treatment for glaucoma by our glaucoma specialist, cataract surgery, treatment of diabetic complications, including laser, treatment of macular degeneration, and treatment of dry eye syndrome. Ultimately, their goal is to diagnose, educate, and treat their patients in a respectful manner, surpassing their expectations. Philips Eye Center has office locations in Naperville and Bolingbrook, Illinois. For more information, call 630-378-4799. Thank you, Dr. Phillips, for your support of this show. So, Dr. Kastin mentioned a little bit earlier that there are some other screening options that are out there, not just colonoscopy, but can you talk about some of the newer technologies that are out there, the newer tests that are out there for screening for colorectal cancer, especially the stuff that we hear about all the time?
Sure. Well, the traditional screening tests before any type of procedures themselves were just a rectal examination and a sample of the stool on a simple card that would just look for microscopic amounts of blood. And that patients would be given those cards, and they could actually mail them in, or they could be done in a doctor's office. And that's always been the traditional way. The more recent way, there have been a number of different, newer, more sophisticated stool type of tests. The most recent one that people have heard about, it was in Forbes magazine, it's an article about Cologuard, which actually was recently in the news. And that's a stool DNA test, but also looks for blood as well. And all of these screening tests, these particular stool, and there are other types of stool screening tests that can be done. These all are good screening modalities. They have a false positive rate, and they have a false negative rate. So it's important to understand that if a patient is going to not accept any type of screening, they should at least get that. There is a chance that this test may be misleading in one way or the other, but at least that they've had that initial evaluation. There have been other screening, the sigmoidoscopy, which is a shorter type of colonoscopy test, has largely fallen by the wayside, and that's mostly because we've started to see polyps growing in the opposite side of the colon that can't be visualized by the shorter colon test. And then there is, some people will read about CT colonography, which is a CAT scan, a CT scan that looks at the colon. And that has come and gone over the years. It has been dependent on different centers doing it different ways. And the medical evidence has been somewhat sketchy, up and down. Sometimes it supports using it, sometimes it doesn't, mostly because the detection rate is variable.
I think I remember when I was a medical student at Loyola, and they had kind of, this might have been maybe the early 2000s, and I first read about CT colonography, and I'm just like, they're like, oh, this is going to revolutionize everything, and it's going to be great, and no more of that nasty prep. And all this kind of stuff, but you're right, it didn't really pan out too much, and you're not seeing much of that being done at all. I mean, hardly at all. Yeah,
Yeah, and I think it's largely because patients actually had to still do a prep initially because they weren't sedated for the procedure. Many patients felt that it was more uncomfortable than having a colonoscopy. And then more recent, the technology has changed so that you didn't have to do a prep, and they could use software analysis to kind of negate the stool in the colon, but it started to miss polyps. So I think CT colonography, even in centers where they were doing a lot of them, has really kind of fallen off. It's still available, and in patients who maybe can't tolerate a preparation or who have some anatomy changes such that colonoscopy is difficult and can't be completed, that's an option. And then a more simple X-ray test, the barium enema, is another option, which is not fun. That's a radiology type of procedure as well. Yeah.
Well, let me ask you a question, because I find myself in this situation quite often. So I'll have some patients that maybe they've already had a colonoscopy, maybe they had some polyps taken out, and then because they're just hearing about new technology, certainly the Cologuard or comparable tests, they'll say, "Oh, Dr. G, can I just use the Cologuard?" And I have kind of a hardline stance on that. I say, once you've seen polyps, I don't even let them go down that pathway of potentially doing a stool test. I say, you had polyps, they've been taken out, you will always need a colonoscopy. Now, I kind of put it hard like that, but I'm not too sure, is that an option for people that may have had polyps, they might be able to go down a stool DNA test or not?
Current guidelines suggest that once a patient has polyps, and there are different types of polyps that form in the colon, so it's really important to talk to your doctor, your gastroenterologist, about what type of polyp was found and where was it found and how big was it. If we're talking about the typical polyps that we look for and remove during colonoscopy, once a patient has had polyps, they need to undergo continued colonoscopy for surveillance. What has changed is that there used to be a relatively hardline stance on how frequent that colonoscopy needed to occur once you had polyps. And even if you had polyps on one colonoscopy and came back 3 or 5 years later and had no polyps, did you continue to have to go 3 or 5 years? And that actually is changing now. If we've seen a patient who maybe had polyps once, and then the next time they had no polyps, and it was a 5-year interval, we may be able to push that to 10 years actually again. So that actually has changed recently.
And I think you kind of hit the head on the nail. We'll get asked that question a bit, and I'm sure people that are listening to the show that have had colonoscopies, maybe polyps, they'd say, well, when do I get it done? A lot of times, actually, I'll ask that question if they come in and I'll say, when did the doctor tell you to come back? And they go, I don't remember. I was coming out of that mild sedative. Go ask my wife or go ask my husband. They were there in the room. But you bring up a good point on how can that happen to know when you need to go back. But I always tell my patients, this is important that you establish a good relationship with your gastroenterologist so you can get the answer right from that person. As a primary care doctor, certainly I can read the notes, but I'm certainly counting on you guys to continue to keep this conversation going on.
And now with the age of medical technology and electronic medical records and secure messaging, it really isn't a problem. I really make an effort to tell my patients, if you have a question, call me, send me a message through the electronic record. And I think some patients find that as medical practices get larger, sometimes there is a barrier to actually reaching your doctor. And that becomes more challenging. Fortunately, with the electronic records, now they can just send me a message directly. And that actually has been great, because then they can just ask away. And I agree with you. Like primary care doctors who always open their doors and make sure that patients have access to them, we need to do the same thing. Just because we practice a specialty doesn't mean that we should be less accessible. We should be just as accessible.
Excellent. I want to talk a little bit about some of the dietary stuff. So there's some things that are out there, and some people will say certain foods may cause colorectal cancer, certain foods may not cause colorectal cancer. I've always been under the impression that yes, we want to have that healthy lifestyle, your low fat, not that pro-inflammatory type foods, less red meat, things like that. Eating more fruits and veggies. And not only from just general health benefits of that, I always look at that to my patients and they say, well, how can I prevent this? Are there any kind of food sources that you advise your patients on what they can do, what can they do to help lower their risk for colorectal cancer?
It's a great question. I don't think that I can tell you very specific food or food groups, dietary habit to practice in that manner. But what I can say is exactly what you were saying, and that is a high fiber diet, low cholesterol, low fat diet. That actually there is evidence to support that that type of diet reduces risk for colon cancer. And other lifestyle modifications, increased exercise, no smoking, alcohol in moderation, and weight reduction. All of those factors actually play into reduction of not just colorectal cancer, but general cancers, all kinds of malignancies.
Yeah, it's interesting on the obesity aspect. I was looking at some research prepping for the show, and we talked about obesity and overweight status are associated with at least 13 different types of cancer. And I opened the show saying there's over 100 different kinds of cancer. But obesity, of the 13 different types of cancer that are associated with obesity and overweight status, those cancers actually those 13 make up 40% of all cancers diagnosed. So we really have to stress the importance of lifestyle. I want to change topics a little bit. I want to get into a little myth versus fact. And this is something that I think with this kind of topic, we're talking about cancer sucks, and we're breaking down colorectal cancer. And by the way, I want to give a quick shout out to my good friend Dana, Miss Dana Davenport, who hosts a show on the same station. I was on her show actually back in March this year, and we did a show, Cancer Sucks. So I want to just make sure I acknowledge Dana for letting me talk to her more about this idea, and certainly allow me to let me use the term that she coined on Cancer Sucks. But I want to go ahead and do myths versus facts, and I think it's important right now to break down some of the misinformation out there. So I'm going to ask you some questions, Dr. Kastin, put you on the spot before we close on down and everything. But so here we go. Myth versus fact. I'm putting you on the spot. Love it. All right. Here's the first statement. There is nothing, and you'll answer myth or fact. Okay. There is nothing I can do about getting colorectal cancer. Myth or fact?
Well, that is somewhat of a myth and somewhat of a fact. Remember, lifestyle modifications and proper exercise and weight management and good healthy living, that actually can reduce risk for colon cancer.
Thank you. I 100% agree on this one. All right, here's a second statement. Colorectal cancer is fatal.
Well, that's most certainly a myth. In fact, the majority of times we actually diagnose colorectal cancer at an early enough stage that we can actually prevent death at all. And that's the whole purpose of screening. So absolutely a myth.
And I think about what you were saying earlier about if you see a polyp, you do a colonoscopy, you see a polyp, you take out the polyp, and knowing that most polyps will lead to colorectal cancer, there goes your risk out the door.
Yep.
Go from there. All right, next statement here. Myth or fact? Screening is only necessary for individuals who have symptoms.
Well, you're baiting me on this one. Yeah, so clearly that's a myth. Patients should have, the screening protocols and the screening guidelines were not developed based on patient symptoms. They were developed based on when statistical populations of patients start to develop cancer risk.
Excellent. Next one here, next statement. We'll do a few more of these. Only people with a family history of colon cancer get it.
That's definitely a myth. Certainly a family history of colon cancer, depending on that family history, certainly warrants colon cancer screening and colonoscopy. But the majority of patients who even develop polyps in the colon occur randomly. So absolutely not.
Yeah. And I say, and then certainly, and you said it a little bit earlier, certainly if there's a family history of colorectal cancer, that person needs to be seen.
Yeah, absolutely. Yeah, absolutely.
All right. Here's the next myth versus fact. Here's a statement. I can't get colon cancer before I turn 50.
Definitely a myth. I mean, as we said already, the American Cancer Society has suggested that colon cancer screening should start at an age less than 50, at 45. And certainly patients who have genetic risk are at risk for getting colon cancer at much earlier ages.
Okay, we'll do two more of these. I like this myth versus fact section. That's
it.
all good. You notice how they're all myths, by the way. This is a foolproof effort to make sure we're giving everybody the right information. So here we go. And I'm kind of chuckling at this statement that I'm about to read to you. Here we go. I think we hopefully answered this question. Colonoscopy is a difficult procedure to undergo and is painful.
Definitely a myth. Colonoscopy generally is not painful for the vast majority of patients, and the pain that some patients may experience typically is a little bit of gas pain after the procedure.
All right, and here's the last myth versus fact question, and I think a myth versus fact statement, and I'm pretty sure this is going to be a myth, but I'm just throwing it out there. We'll find out. Once you are diagnosed with colon cancer, it is too late to do anything about it.
Definitely a myth. In fact, the most important reason to get screened is in order to find colon cancer if it's present at an early enough stage so it can be intervened on. In the vast majority of patients, we manage them, and these patients have a long, healthy life.
Excellent. So we got just a few minutes left, about 5 minutes left, and what I want to do is kind of certainly kind of close things down. I think this is a very good discussion because we're talking about, again, cancer sucks, and we're talking about colorectal cancer, which again, the second leading cause of cancer death when you combine men and women in this country, but it doesn't have to be. And so we're talking about just breaking down some barriers that are out there, getting people access and getting people information, the correct information. So I want to ask you this, and maybe you can kind of summarize things up for me, Dr. Kastin. If you had to kind of like a few take-home points to people out there that listen to the show, or they're listening on radio or watching us on Facebook Live, and they're saying, what should somebody take away from hearing us talk? By the way, I love this conversation, me and you. We can probably keep going on, but what are some things that are out there? What should somebody who's listening to us talking about today, what can they do starting today or starting tomorrow when it comes to colorectal cancer? Whether it's like with a loved one or themselves or a family member, what can we do? What are some take-home
Well,
points?
aside from the healthy lifestyle changes that I think are invaluable, I think that the most important thing is this type of dialogue. Patients should hear this. Reach out to your doctors. Ask your doctors questions, and ask them whether or not they're an appropriate person, and as a patient. And I think that patients should discuss that with their family, and I think that they have to try and get through the fear and the myths, which hopefully we've been able to dispel some of them today, and that becomes important. After that, getting to the doctor's office isn't the hard part. We can get these patients in, we can see these patients. So we just need to know that they're aware and talking about it.
Excellent. And my final thoughts are this. If you're concerned about colon cancer, or if you have a strong family history of colorectal cancer, again, talk with your doctor. Talk to me. Talk to physicians like Dr. Kastin. Talk to somebody and ask, what should you do? Remember, I want people to talk about colorectal cancer awareness and cancer in general, so don't be afraid. Have this conversation every day. Don't be afraid to talk about cancer risk or cancer prevention with your doctor. And I think as you do that, you'll break down barriers, you'll feel more comfortable about things, and you'll be able to continue to stay on this pathway towards healthy living. So what I want to do right now, I want to thank my guest, Dr. Darren Kastin, board-certified gastroenterologist, as well as board-certified obesity medicine expert with Suburban Gastroenterology. Check them out at www.sgihealth.com. I want to thank my platinum level sponsor, Phillips Eye Center. Thank you again so much. Stay tuned for next week's episode. We're going to be doing Cancer Sucks Series Part 2. We're going to be talking about breast cancer. Remember, my name is Dr. Mark Gomez. Check me out on my website, www.drmarkgomez.com. Until next time, see you next week, and peace out.